Could neural tension sensitivity be the culprit behind your patient's pain? In this episode of our lumbar skills series, we're zeroing in on neural tension testing, a critical but often overlooked and misunderstood part of the assessment. Learn how to identify and pinpoint its contribution to your patient's pain, plus whether or not you should be flossing it. So, when most people are looking at neural tension, what are they looking for, Caitlin?
They're looking at the slump test.
They're looking at the slump test, which is a great test. What do most people think a positive slump test is? Reproduction of your patient's pain. That's what most people are taught, is that you need to reproduce your patient's pain in order for it to be a positive test. And that, ladies and gentlemen, is not true. What you're looking for is an asymmetry. You're looking for a difference side to side, right? Let's start off with looking at the slump test. If you want to take your shoes off for me, that would be fantastic, because I don't want to touch your dog poop shoes. Just kidding, there's no dog poop on her shoes, but you never know. There could have been, right? I like to take people's shoes off so I'm not holding onto the bottom of their shoes. When we're looking at the slump test, first thing we need to do is clear the joints and make sure that she can tolerate being in those positions. Otherwise, we might just jam her into a position that is very painful unknowingly, accidentally, right? So first things first, can you go ahead and just slouch for me, right? Let your hips roll back. And that is a key point there. When I'm doing that, when sit up again, I'm holding her here and I'm pushing her hips back. A lot of times when people do this, they have their chest go forward. And this is not a good testing position. Why? Because the slump test is a neural tension test in a flexed position under load, right? When we sit up tall, you're at about 140% of your body weight on your low back. When we slouch, then that jumps up to 185%. When we forward fold, that actually takes away some of that loading. So, go ahead and let your hips roll back. How does that feel there?
Fine.
Any discomfort?
Nope.
Okay, go ahead and sit back up for me, comfortable. You okay there? If you bring your chin down to your chest, how does that feel there?
It feels fine.
No pain?
No.
Okay, and now you just stay there. Don't move your knee, but just bring your ankle up. Feel okay on that side? Mm-hmm. And then how about on this side? Okay there? All right, now keep your foot up and slowly straighten that knee out. How does that feel there?
A hamstring stretch.
Hamstring stretch, okay. Go ahead. Go back up there if you feel a hamstring stretch. Feel it there? Mm-hmm. If you point your toes away this way, worse, better, the same?
Better.
Okay, go ahead and come back down. And then what if we compare that to this side? Ankle first, and then slowly bring that up.
Yeah, still a hamstring stretch.
Pretty similar to the other side. And if you point the toes away?
Better.
Good, go ahead and relax. So now I know that that's not actually a hamstring stretch, that's a neural tension stretch. But at that point, not necessarily a problem, because end range neural tension is normal in adults, right? Again, we want to look for asymmetries, which could be range of motion, intensity of stretch, like where she feels it, things like that. So now we can put it all together actively with her doing it first. So go ahead and slouch for me, let your hips roll back. You okay there? Bring your chin down to your chest. And now, starting on this side, bring your ankle up and slowly bring that knee up till you feel a little stretch. Stretch there, right? And then if you point your toes away, you okay there? Good, go ahead and bring it back down. Was that worse, better, or the same when you point your toes away?
Better.
Okay. Is it more intense or less intense, or about the same in this position versus the first time you did it? Do it again. Go back down, bring the ankle up, and then straighten that knee out.
Kind of less.
A little bit less there? Okay. And now what if we compare that to this side? Ankle first, and then the knee.
That's fine.
No stretch there?
No, not really. Well, a little bit.
Okay, so different than what it was before.
Yeah.
Okay, so that gives us some information without me doing anything, right? Without me actually touching her. So we know on this side it's less, that side is more. Now that is an asymmetry. Well, what's changed, right? We've actually taken up more slack through the nervous system with the slouch, and we've added loading. Why is it less bad? It changes the position of the spine. So we'll get into that in a minute. So first, I'm going to run through this. And since I know that this is the least symptomatic side, I'm going to start on this side. So go ahead and put your hands on your lap for me. That's a big indicator a lot of times, or a big point. A lot of times people will sit and they'll put their hands down here and they're taking the load away, right? So we want to put the hands on the thighs, or you could have them put them behind their back if you wanted to. We just want it so they're not supporting themselves on their arms. So we're slouching, chins down. I take my hand, I'm going to put my thumb pointing up the back of her head, and I'm going to rest my pinky down her back. So I'm monitoring the cervicothoracic junction. So if I lift up here, lift your head up as I go, I can feel that, because people will sometimes do this, where I lift up and they bring their head up, right? And they're actually just buying slack to the system there, right? So it's giving you false results. So since we're going to be looking down, we want to make sure that something is monitoring, make sure that doesn't happen. Go ahead and relax for a second. The other key point I want to make is if you have a high-low table, use it. Bring this thing up. The number of times I see therapists like way down here in bad positions where they could just bring the table up is a lot. You know, anytime any of my clinicians have the table down and they're in a bad position, I just walk up and hit the button and adjust the table for them. And I was like, oh, thanks. You are going to do this every day, right? Maybe not this test, but you're going to treat patients for a long time. So we might want to make sure that we're in fairly decent positions with good body mechanics throughout the day so we don't end up jacking ourselves up. So I bring the table up. Now I'm going to have her slouch, chin down, hold here. I'm in a wide stance. I'm actually leaning on the table, right? I'm not going anywhere. So now I'm going to hinge down. I'm going to push her into a little bit more knee flexion because that puts more slack on the system, and then dorsiflex. How does that feel there?
Fine.
All right, I'm going to lift up. Let me know if anything changes from what you feel right now, even if it's just a stretch, okay? As soon as it does, if it does. Any pulling or stretching, right? So I'm immediately checking in. No stretching, no hamstring pulling. As I go, I'm walking my thigh in underneath her so I can race it there. All right, no hamstring stretch, no pulling, no pain, nothing in your back. Feel okay there?
Yeah, just a little bit right there.
Where do you feel that?
Bleeds right here.
Okay.
It's like very mild.
Okay, keep your chin all the way down. If we do this, worse, better, same.
Better.
And let me know as soon as that comes back, if it does. Anything yet? No stretching yet?
There.
And if you look all the way up towards the ceiling, does that change it at all?
Yeah, it goes away.
All right, keep your head up. Kind of go a little further here. Perfect. So now we know that there's no adhesion, which means that I don't need to floss that. That wouldn't tell me that it needs to floss anyways because that wouldn't tell me there's an issue anyways because it's end range. But now I can see I can take up slack on one end, give slack from the other, and take it up so I can feed the slack through the system. Nothing is stuck. Let's compare that to the other side. Slouching, chin down, you okay here? And again, same thing. Let me know if anything changes from here. No pulling, no stretching. Nothing going on yet?
I feel a little bit of a stretch there.
Where do you feel that?
Like behind my knee.
Okay, so this is a bit sooner than the other side, so an asymmetry. So keep your chin down there for me, and I have my thigh underneath so I can pin her leg between my forearm and my thigh, hold at her ankle so her knee doesn't move, and let this drop. Is that worse, better, or the same there?
Better.
All right, so let me know if and when that comes back. Anything yet? No pulling?
There.
All right, if you go all the way up nose towards the ceiling, worse, better, or the same there?
Better.
And then can I go a little more here? Perfect. So again, an asymmetry, but there is no adhesion because we can give and take slack. So that's the flexion-based slump that most people are familiar with. What most people are not familiar with is this extension-based slump, which then is a loaded position in extension. So let's see how these results differ for Caitlin. So, and these are real results. You're not making this up, right? These are real. Okay, just making sure. These are real results. So go ahead and sit up nice and tall for me. So I do a little NDT here, or I think that's what it's called, right? Whatever, it doesn't really matter. I'm just giving an up and in motion to encourage her to sit there, and I'm going to keep my hand on her lumbar spine, keeping that up and in pressure there. Because as I pull this up, if she gets stretching her hamstrings, right, which is there, she's going to relax and let that slap. So I want to make sure that that does not happen because we're changing the spinal position at that point. So sit up tall, you okay here? No pain, no tightness, nothing going on?
It's a little tightness
Tightness where?
in the back.
Okay. Doesn't bother you? All right, chin all the way down your chest for me. You okay there? So now I'm going to have to monitor here and here. So let's keep an eye on her out of the corner of my eye. If I come down here, you okay there? And as I lift up here, let me know if anything changes as soon as it does. Any pulling or tightness?
I feel some tightness
Where do you feel tightness?
behind my knee.
right? She wasn't going to tell me that. That's why I check in, right? She would tell me when it gets a lot stronger. We want to catch it when it first comes on. Doing okay here?
Mm-hmm.
All right, so again, sliding my thigh underneath there. Stay there. Keep your chin down. Don't slouch at all. Hitting with my forearm. And if we do this, worse, better, or the same.
Better.
And then let me know if that comes back as soon as it does. Anything happening yet?
Right there.
All right, if you go nose all the way towards the ceiling, worse, better, same.
Same.
Same. Okay, so go ahead and bring your chin back down. And then let me know when this first goes away.
It's gone.
All right, and when it first comes back.
Right there.
And if you go nose all up towards the ceiling there, worse, better, same.
Better.
Up, go all the way up, and then kind of come a little further here.
Yeah.
Good. So go ahead and relax. So what did I do there? I just fine-tuned it, right? If you're too far into symptoms, then you might not be able to alleviate it by giving slack. So you want to find right when it first comes on. All I did was flex her. I held her dorsiflexion and I flexed her knee back down until it went away, and then very slowly came up until it came just back. And then we got a difference. Whereas before, when I was a little bit too far, we didn't get a difference. So these details are very, very important. So then now let's compare that to this side over here. We'll sit up nice and tall. And then we bring this here. Same thing, chins down. Let me know if and when you get any tightness or pulling here.
Feel some tightness there.
All right. Let me know when it first goes away.
Right there.
When it very first comes back on.
Right there.
Okay, now keep your chin down. And if I do this, worse, better, same.
Better, I think.
Okay, so if I come back up here, is this worse?
Yeah.
All right, so down here is better?
Yeah.
All right, let me know when it very, very first starts to increase.
Right there.
All right, and then if you go nose all the way towards the ceiling, worse, better, same?
Better.
Better? Okay, keep your hand up for me. And if I do this, take a little more slack up. Perfect, perfect. Right, so now you can see that there's an asymmetry. So here, just so we can get it on that camera over there, if we do this, let me know when you first get it.
Right there.
All right, and then we compare that over to this side here.
Around there.
Right, so there compared to,
There.
right, difference in the range. Also different with the flexion-based slump versus the extension-based slump. So now, if we did that test with looking up towards the ceiling, and even though we fine-tuned it, it didn't make any difference, we do not assume that that's an adhesion. We go for another test, which is an attractional alleviation test, okay? And if it does not get worse with adding traction to the system, it can't be an adhesion. Every time I add traction, it just adds more tension to the system as a whole. So I'd put her in that position, hands, actually I want you to hold onto your elbows here, sit up nice and tall, chin all the way down, and then we're gonna do this side for demonstration purposes because it's less sensitive, but bring your ankle back up, bring this up here if you get a little bit of discomfort or a little tightness, hold it there, still feel it there? All right, so stay there, you doing okay? And I'm gonna come behind her and I'm just gonna give a little bit of traction here. If I do this, worse, better, the same.
Yeah, better.
Okay, so cannot be an adhesion. All we're doing, well, actually, we're doing two things. We're taking the load away, and we're actually adding more tension to the system. So that's neural tension test 1 and 2. Go ahead and lay down on your back for me here. Be nice, you guys. Give your patients a pillow. So when we're looking at this straight leg raise test, you want to straighten yourself out. You're like crooked out the table there. Again, I'm going to start off on the least symptomatic side so we have a baseline here. So we pre-dorsiflex, right? Because this is where you're going to get the biggest change in neural tension. It does not make sense to bring somebody up and see, do you have symptoms here? You do? Okay, if I do this, does it get worse? It's just not nice, right? Like, oh, that's uncomfortable. Can I make it worse? Oh, now you're in a lot of discomfort. Oh, no wonder you're feeling worse after the evaluation because I just did a whole bunch of mean things. Let's do nice things, alleviatory things. So let's take up the slack here. Any discomfort or tightness here. And then as I lift up here, right, I keep her dorsiflexion. I put my other finger right above her knee because what will happen is people will sneak in a little knee flexion there. So to make sure that doesn't happen, I'm going to bring this leg straight up. Let me know if when you get right there. All right. Let me know it goes away.
There.
All right, when it first comes back on.
There.
So I'll hold right there, stabilize the ankle. If I do this, worse, better, or the same.
Better.
Right, and sometimes people will add flexion from the cervical spine, and you could. It adds a little bit more load to the system. as well. And if we've already cleared out with the slump test that there's no adhesion, we don't need to go doing that in this position as well, because we already know that there's no adhesion. So go ahead and bring your chin all the way down to your chest. Like, lift your head up, bring it down. Yep. And then now here, let me know if we need to get some discomfort.
There.
And if you bring your head down, worse, better, same.
That's the same.
Right? So I don't like doing that. I don't find it gives me good information. It can be irritating for patients. And I've already cleared out the adhesion, right? You could also bring their leg up. Like, oh, when you bring your chin on your chest, does it get worse? But we don't want to do that. The reason that it doesn't get much better when we bring the chin down is because we actually need to get into cervical extension, not more of a neutral position. So we need the head of the table down. It gets super weird. So you just don't need to do it, okay? There, we know she has some neural tension sensitivity. And let's compare the other side, which, by the way, we want to see somewhere around 70 degrees, at least 70 degrees of hip flexion for that to be a negative test. So let's compare that to this side over here. You okay in this position?
Mm-hmm.
All right, let me know if anything changes.
Kind of there. Yeah.
And then if we do this,
That's better.
all right, and if we do a little bit of this,
That's worse.
right? So now we know that it's neural tension. It's not hamstring. It's not anything. Hamstring stops here, right? It doesn't go all the way down. Sometimes people will get tension, neural tension here. They're like, oh, it's tightened my calf. Except for it's not tighten their calf, or else they would just have calf tightness and standing, and there would be a lot of resistance there, right? So then this test, I didn't mention, I brought the table down so I don't have to be way up here, right? I could bring it even lower if I wanted to, just so that I'm not holding way up in these weird positions. So this is a test for neural tension sensitivity in extension with a lot less load, because when you're laying flat on your back, you're at 25% of your body weight on your spine. But you're in a lot more extension than you're going to get into in sitting, because the sacrum's pushing into the table, causing extension in the lumbar spine. And you can see she's very sensitive with this test. Now, what else happens is that the psoas kicks on to assist hip flexion. That's important because the psoas connects from L1 to L5, and it connects right to the discs, the anterior fibers of the disc from L1 down to L4. So as I'm lifting the leg, what's happening at the other end, right? It's pulling on the leg, but it's also pulling on the spine, which is going to create more segmental extension and more compression, more loading. So we can do another variation of this test with a pre-flexed hip, where we flex the hip here, and then we go into it. Let me know if you get any tightness here.
Right there.
All right, and then if we do this, worse, better, same.
Better.
Right, so now we know the loading's not too big of a deal for her. Right, we can compare the other side. Same thing here, pre-flex to 90. Let me know if we get any discomfort or tension or tightness. You feel a little bit there?
A little.
Yep, and then if we do this.
Better.
Right, so that I know because I picked up on her little cues where she goes, she's thinking about it. I think I feel it. People aren't going to tell you that they feel it until it's stronger, right? We don't know when it first comes on, which is why I do a little bit of that fine tuning, I call it, of going back to where it goes away, coming right back up. I pay attention to her facial expressions and other mannerisms that are going like, oh, I think I feel something. I can tell. She hasn't told me yet, but I asked, and she was like, yeah, a little bit, I think. Right? And if somebody's arguing with you about it being their hamstring, right? Don't argue with them. Just have more testing, right? You can educate them of like, hey, can you explain to me? That's a great way. Ask them to explain it. If your hamstring starts here at your sit bone and ends here, how does changing your ankle affect your hamstring? And they'll be like, well, I don't know. Well, exactly, because it doesn't, right? And you don't argue with them, just ask them to explain it, and they won't be able to, and then that will allow them to realize that, oh, maybe it doesn't make sense, but you're not butting heads. You can also do a little bowstring test. You okay if I do that? Mm-hmm. Where we're going to manually stretch the sciatic nerve. Scoot over to this side of the table for me a little bit. Where we're going to get up into that position, since we can create symptoms here, and you'll find lateral hamstring tendon, and then you'll find medial hamstring tendon, and there's a soft spot right in between the two. So then you just take your thumb and put it laterally between the two, right behind the knee, right, kind of pushing into the popliteal space. And then as you extend her leg, you can play with her ankle dorsiflexion, plantar flexion, and you'll feel something start to move and pop out. That thing that you feel pop out as you start to extend the knee more, like down here I don't feel it. Up here I start to feel it. You a little tension there? That's the sciatic nerve popping out. So then once we know that our thumb is covering the nerve, we can put her in dorsiflexion, slowly extend, say, hey, let me know when you start to get some of those symptoms. You feel it already? And if I push on that nerve, how does that feel?
Not great.
Right? And then if I just do this, I'm still pushing here.
Yeah.
Better? Or you can just bring it down and say, hey, I haven't moved my thumb. If I push here, how does that feel?
Fine.
Right? So it's not just a sensitive, tender spot to push on. And that's because the sciatic nerve takes a shortcut in the popliteal space. And as we start to extend the knee, it becomes more superficial. And as we add the dorsiflexion, it puts more tension on it. So then we can manually add tension. And that's a good differentiator if you're not sure, if she's not sure. I don't go doing that in a lot of people because it just typically causes more pain. But I'll use it as an educational tool or differentiation test as needed. And then as far as moving the foot in different positions to test, the tibial nerve or the peroneal nerve or any of those other things, if you have to get right to the very end range and you have to fully stretch things, it's not that big of a deal, honestly, right? Like if you have to fully extend all the toes and get right to the end range, like I think I can make it happen, like you're forcing something to happen. And you can find irritations. You can create, is what I meant to say. You can create irritations that aren't really a big deal. And honestly, it all comes down from the sciatic nerve. And the prevalence of actual entrapments or things being stuck distally is very low. And there usually has to be some mechanism for that to happen, like a crush style injury where now you have physically created something. Like that happens to me in this arm because I had a motorcycle go through my arm and into my nerve. And if I tap here, I get like zings all the way down and there's all kinds of crazy stuff that happens. And that's gotten less over time with natural movement, not because I'm sitting there flossing it. Before I couldn't do anything, and in going to a median nerve tension test, it would just light me up. And it was stuck here to here, but it didn't get better because I sat here doing this. It got better because I just let it be and use my natural movement. Because when you move naturally, the nerves are sliding inside of the dural sheath, right? The argument for neural flossing, glides, slides, tensioners, is they improve the neurodynamics. But if we can give from one end and take from the other, then the neurodynamics are an issue. It's a sensitivity. Just like spraining somebody's ankle, we're not like, oh, the problem is that your ligament doesn't move. No, the problem is that the ligament is injured and sensitive to that right now. What do? We create an environment with the body that's conducive to healing, allow it to do its thing, and then we'll start working into those ranges once the recovery has happened, right? And we start dealing with all the strengthening and dealing with anything that's gotten stiff along the way. And then as far as the femoral nerve, we're not going to go over that because you most of the time don't need it, right? Like if somebody has an upper lumbar nerve irritation, that's when you're going to want to test the femoral nerve. But almost all of the time, it's going to be a lower lumbar irritation because L5 is a natural hinge. You get more motion from there, and that's why those nerves get irritated. Things in the upper lumbar typically tend to be more of a hypomobility issue, right? So yes, maybe every once in a great while you might find that, right? It is a real thing. But for most people, it's going to be a lower level nerve irritation, especially if they have pain, tightness, numbness, tingling, all that stuff down through there. And then honestly, unless somebody's doing like a couch stretch all of the time and they're putting themselves into these positions a lot for whatever reason, then we don't need to educate them on avoiding those positions, which is what we need to do to allow the thing to heal. It's not keep stretching it and irritating it more and more and more. The tricky part is that it feels really good for people when they stretch, right? Like, oh, I've got this tightness in my hamstring, let me stretch it. And it feels good for a lot of people in the moment. It's kind of like smoking crack. I smoke crack. I assume people feel good in the moment. That's why they do it. What happens when you keep smoking crack long term? Well, like a credit card, right? Like you can go swipe your credit card right now all you want, and you don't feel that pain until you look at your statement later or you get the bill in the mail and you're like, oh my God, $2,000, what did I buy? It's a whole bunch of like $20, $30, $40, $50 nothings, right? Same thing there. You're just swiping the credit card. So when you get them to stop swiping that metaphorical credit card. Also though, when anybody describes tightness and they're just standing there, you can sit up if you want to. When people describe tightness, the sensation of tightness has absolutely nothing to do with actual tightness, right? When people are like, oh, my hamstrings are so tight all the time. Well, if you've ever done a hard workout and your hamstrings have been so sore that like you start to flex your knee, you're like, oh God, that's not good. You start to bend forward, you're like, oh, that's uncomfortable. When you're standing there, when you are that sore and you're just standing here, you don't feel the tightness, right? That's not the way it works with the muscular system. In order to feel the tightness, you have to start to put tension through the muscle. And that when we're standing here, right, it extends the hip, flexes the knee. We have to flex the hip, extend the knee to start to get tension, right? And if it was that tight, they wouldn't be able to take a step, right? So that sensation of tightness is typically a dead giveaway that they have some neural tension sensitivity. It has nothing to do with actual tightness. And that's it for today's episode, guys. I'm Doc Raj.
I'm Doc Caitlin.
And we're the co-founders of the Performance Rehab Authority. Hopefully you guys took some good lessons away from this episode. Take this stuff, apply it to your caseload immediately, and leave a comment. Let me know how it goes. We'll see you on the next one.